So to refute that, we have Dr. Anand Annamalai from Madurai. He is also a well-known endocrinologist from Madurai. So he is going to say that the ADA guidelines is the best. So let's see what he has for us.
It's great being at Trendo 2018. It's also great debating science and debating with my good friend Swami. So Swami, he said Madurai versus Coimbatore. Literally Madurai in the pona mat theriyala. Madurai maradhan pesraru. Anyway, my side is yes to ADA. Our chodamari, you just have to unlearn what you just learned from him. Because what Swami said was basically he was just trying to convince you and actually confuse you. So what he was trying to do is basically confuse you completely. He was trying to say, like, diabetes has increased for the past 10 years because of global warming. So something like that. So we were all on the same page until 2017. 2017, ACP did nothing. They said metformin and then less than 7. Suddenly one year they found 2018 and they decided we've not done any guidelines, so let's issue a guideline. So that's a problem. And they said we are very robust and we've basically got statistics inside. So my issue is only with guidance statement 2 and 3, and that's what I'm going to talk about here. So this approach with what the ACP has done has created a new disorder called glucocentricity. If you look at it, it's an irrational belief that whatever you do with glucose, it'll have a good outcome. This is pretty wrong. And also statistical eccentricity. Just imagine if a statistician goes on a war round, says, does it work? And then they say, it depends on what you mean by does, what you mean by work, what you mean by it, and when you do it. So it's exactly the problem with ACP right now. So what is the best situation? Look at the A1C above and A1C below. It's about the same, is it different? Or you look at this, A1C 7, which basically has, peaks and troughs, as what Swami is mentioning, or, A1C, which is quite stable. Remember the important aspect. With the A1C increasing, the microvascular complications increase. But equally, the cardiovascular complications increase, but not to the extent of the microvascular complications. And that's what makes it very important. So, and this is what is important, which we need to understand. But we do know that from studies, study is important. This is science. So, Swami Janara na science pesala, but I have to talk science because this is evidence. So A1C, whether it is cardiovascular disease or microvascular disease, whether it's an Asian study or whether basically you look at an American or a European study, has shown that basically the higher, the worse you do with complications. And also we know, but by correcting it right from the UKPDS, that a 1% reduction creates a good improvement amongst all the microvascular and macrovascular endpoints. So that is very important. So either which target is ideal to prevent complications, that's very simple. You need an A1C which is good. And we're not talking about strict glycemia, we're talking about good glycemia. So it's not no glycemia. Now let's come to the point is, are we really achieving HbA1c targets? Now we are following targets as per, ADA so far, AACE so far. And you look across the globe, we don't achieve targets. So if you start increasing the targets, that begets slackness in achieving it. You look at India. So this is Dr. Shashank Joshi's data, and he says basically that the mean HbA1c in India is 9%. If you say your target, you need to reach 7, and people reaching 9, enna koduma sir neenga pesringa? Enna koduma idu? Edukku indha debate idu? We are debating about relaxing HbA1c targets when basically we basically are doing so badly. So importance is you have to understand trials, and the timing of trials is important. And not only the timing, but it's also the duration of diabetes which is important. So UKPDS, diabetes, limited cardiovascular disease, diabetes of less than 1 year. And this trial went on for 10 years. The Steno-2 was a high cardiovascular risk, and it went on for 8 years. Advance went on for 5 years, and Accord and VADT had high cardiovascular disease risk factors. And the duration of diabetes was completely different. The other issue was the target HbA1cs. So this is where the problem was. I selected these trials because basically these are the trials which the ACP has come to conclusions. Now clearly the A1Cs with the Accord is A1C 6.4, Advance it's 6.3, and Steno it's 6.5. But let's delve into this and try to kind of unravel this. So if you look at all these trials, UKPDS showed good evidence for microvascular, and it showed good evidence for macrovascular down the line. Because macrovascular is an atherosclerotic process, it's going to take some time for things to correct itself. Whereas if you look at the other trials, these were people with diabetes for a long duration of time. So how can you expect them to improve within 3 years? It's not possible. And if you look at the microvascular subset in all these trials, there's an improvement. So we know that improved glycemia actually improves microvascular outcomes. The macrovascular, it depends on the duration of diabetes and who you treated and how you treated. And this basically brought this legacy effect from the UKPDS that initially, a good glycemic memory basically is retained by the tissues and that has benefits later. So this legacy effect was actually ignored by the ACP. So, Swami சொன்னாரு நல்லதே பண்ணணும்னு சொன்னாரு ஒண்ணுமே பண்ணலன்னா என்ன அர்த்தம் you got to do something, right? So the metabolic memory is important. So the metabolic memory at that time you got to treat intensively. There's no point going and jumping on them later in life. So if you look at the ACCORD analyses, so because he quoted ACCORD, I'm going to just delve into that and tell you a few things. So this was 60-odd age people, median duration of diabetes of around 10 years, and cardiovascular disease proportion was high. Now, you look at this, two issues. Weight gain was very high in the intensive arm, and the hypoglycemia was very high. Why? Because you were trying to correct sugars very quickly for a high cardiovascular disease population and very strictly. So you want 6.4, they dumped everything on them. And what did they dump? If you look at this is a randomized controlled trial. And if you look at the intensive and standard therapy, this was way back in the early 2000s. You find that the thiazolidinedione and actually rosiglitazone is very high in the intensive versus standard. So it's what you use. So you used an agent which you're not really using now, and you use a lot of agents at a very short time, brought the A1C very quickly, created hypoglycemia, created weight gain, which obviously is detrimental. If you look at the subgroup analysis, this actually tells you something. Now, whether it is the primary outcome or death, when the A1C was greater than 8, the mortality was higher. But whereas it was less than 8, it was better. Meaning to state that if you're already at a level when your glycemic control is good, that is, you have a good legacy, and then you try to control, you have a good outcome. However, if you start already very late, there's no point going and treating glycemia, because the glycemia is not important at that point. You have other things to tackle off. So this suggests that the benefit of primary prevention and lower HbA1c at baseline is very vital. You look at advance, the same thing. Age, duration of diabetes, and the A1C at baseline. If you look at the agents they used, again, if you look at the thiazolidinedione, end of follow-up, look at that. It's higher. You look at subgroup analysis, 7.2. So this was 7.2. You look at greater than 7 point less than, so not much of a difference. But look at this, body mass index greater than 28, bad effect. History of microvascular or macrovascular effect, bad effect. So this is actually giving you a story. So the message which it said was higher mortality was related to a high-risk patient. The duration of diabetes was important. What you used, usage of glitazones, high baseline HbA1c, a rapid reduction of HbA1c, increased weight gain, hyperglycemia, all these were important factors. And what's important for cardiovascular disease? It's not just glycemia, it's multiple intervention. You use, as Swami said, you got to focus on blood pressure, cholesterol, and glycemia. And now ACP says A1C 7 to 8 is important for most patients. How can you say this when all this is going on? Now, Steno-2. Now, Swami mentioned that Steno-2 was a very good trial. He quoted it. Now, you know what? The A1C target there was less than 6.5. They looked at 6.5 or less in a population which was 5 to 8 years of diabetes. They looked at cholesterol, they looked at blood pressure, and they looked at the patient as a whole. And they achieved a very good effect. They had absolute reduction in death, absolute reduction in cardiovascular death, and they had a very good effect which actually started late, not in the initial years. So the first 8 years, there was no mortality benefit. The mortality benefit actually happened only after 8 years. And 13 to 20 years down the line, you had this effect. Now, ACP didn't take this into the equation. The A1C here was less than 6.5, and this was a population with diabetes of 5 to 8 years duration. So ACP clearly is glucocentric, it ignored Steno-2. So it's like saying, oh, statistically this person, really didn't need a good HbA1c, but realistically it might not have helped, basically, it might have helped. So after you die, what's the point in saying all that? So the target, what I'm trying to drive, must be individualized with a multifactorial intervention. The other important aspect is microvascular endpoints. Now, microvascular endpoints are ignored. Now, if you tighten glycemic control, this is a multivariate meta-analysis looking at two particular aspects: death from kidney failure and need of dialysis. And this showed that if you intensify treatment appropriately, you basically have a less need for this. So who has the best evidence in terms of micro and macrovascular? It clearly is ADA. They've taken all this into the equation. The AAC has taken all this into the equation, and that's how they've brought this into the picture. The other one, recent cardiovascular outcome trials have not been taken to the equation. As I said, 2017, they were just dreaming until 2017. All of a sudden, in 2018, they put out basically saying, we have evidence from what emanated 5-6 years ago. So they've ignored all these recent trials, all these recent data. There's fantastic data now to state that you have agents in diabetes which you could use in this complicated subset, which actually improves cardiovascular outcomes. Now, ACP says 7 to 8 for most patients. Now, think about this. And if you look at these recent trials, they actually treated a target, and they treated as per what the ADA and the AAC was recommending, and also individualized these patients. So diabetes therapy, I would say, relaxing HbA1c is letting loose a criminal. So you got to look at the age of the patient. You got to look at the duration of diabetes, microvascular events, the beta cell function, whether they have macrovascular events, if they're young, they have pregnancy planning, whether they have infections, chronic infections, diabetic foot, weight management, hypoglycemia. So this is all these things you need to take into consideration. You just can't say, oh, we'll just leave it. We won't do anything about it. So it's not just about the number. So the physician's dilemma, I'll give you 3 cases. So he gave you a few cases. So someone who's 34, A1C 6.4, and she wants to basically fall pregnant. ACP says de-intensify pharmacotherapy. Now this person wants to become pregnant. Case scenario 2, a 56-year-old with atherosclerotic cardiovascular disease on metformin and A1C is 8. What do? ACP says atherosclerotic cardiovascular disease, leave it there, 7 to 8. Case scenario 3, someone who's close to 70, had a PTCA, is having an A1C of 6.4, is actually on metformin, liraglutide, and empagliflozin, based on the recent trial evidence. So what would you do? Would you stop something? Would you withdraw something? You would probably try to scale it down, but how would you go about it? So this is a dilemma. The story of A1C is a story which may not have a very happy beginning, but it will have a happy beginning if you hit hard early and treat appropriately so that you have a proper end, and the rest of the story would be good to look at. So I think the ACP has to kind of look at problems within them, and they have to unite with the other guidelines and just not say, oh, I want to issue a guideline based on evidence. I think that's what it is. So நானும் தமிழ்ல சொல்றேன், HbA1c less than 7 ஆனா குறை சொல்றாங்கன்னா HbA1c மேல தப்பு இருக்குன்னு அர்த்தம் இல்லை. யாருக்கு எப்போ எப்படி எதை வச்சு HbA1c less than 7 ஆக்குறது தான் முக்கியம். It's not just a number. That's one. இன்னொன்று வந்து காகிதத்தை கசக்கி பார்க்கும்போது குப்பையா பார்க்குறோம், காசாக்கும் போது கடவுளா பார்க்குறோம். HbA1c அதே மாதிரி தான், காகிதம் மாதிரி தான். குப்பையாவதும் கடவுளாவதும் நம்ம கையிலும் இருக்குது, பேஷண்ட் கையிலும் இருக்குது. இதை ரெண்டையும் தெரிஞ்சு தான் நம்ம யூஸ் பண்ணணும். சும்மா பிளைண்டாக போட்டுட்டு நம்ம பண்ண முடியாது. ஸோ வாட் ஷுட் தி கரண்ட் ஃபோக்கஸ் பி? Individualized targets with early intensive diabetes treatment with multifactorial treatment. And that's what I would say. I rest my case. Evidence is actually with the ADA, and I would say game, set and match to ADA. Thank you very much for the opportunity.
Thank you, Anand. நிறைய கிராஃபிக்ஸ்லாம் போட்டு கலக்குனாரு. So Anand says that Anand says that ACP guidelines are more glucose-centric, whereas ADA guidelines are more rational. So